Okay, we're beginning the lower extremity part 2 lecture for anatomy class. These are your thigh movements that occur at the hip joint. Medial rotation will be the same as internal rotation. Lateral rotation will be the same thing as external rotation. You see how the positioning of that lower extremity is. You can see that the foot is turned externally or laterally or outwards, and we are pointing the foot towards the midline of the body. Medial rotation or internal rotation, forward for the F flexion, for thigh flexion or hip flexion, and extension is coming back from flexion. Abduct is going away from the midline, adduct is going towards the midline. You can see here we have knee flexion and extension. Knee flexion occurs posteriorly, elbow flexion occurs anteriorly, if you want to think of it that way. And the extension is going towards the degree 0. Your surface anatomy muscles, here's your tensor fasciae lata muscle is located. It is right here. It inserts in the IT band, which is this fibrous fascia that keeps the lateral compartmental muscles of the lower extremity in place. Then we have your sartorius muscle, your rectus femoris, vastus lateralis. The abductor muscle group is right in this region. Their main job is to perform hip adduction towards the midline. Vastus medialis is right here. Is teardrop muscle. Patella. It's labeled here as patellar ligament, but as per anatomist language and clinical language, we call it patellar tendon. Correspond these surface anatomy findings to these anatomical diagrammatic drawings here as well. Thigh muscles, anterior compartment consists of when discussing the muscles in the lower extremity, we want to compartmentalize these muscles. The anterior compartment consists of the following muscles you see here in red. Your pectineus, your sartorius, your quadriceps consist of 4 muscles, which are listed here. You'll be needing to identify these structures on the diagrams as you see here. Here's your pectineus muscle, originates from the pubis and inserts on the aspect of the femur. What this does is contracts. The anchor is the origin at the pubis, and it contracts it, pulls on that femur, the thigh bone, and brings it towards the midline, causing adduction. This is what similarly the rest of these inner thigh muscles do. Your sartorius is this long, slender muscle here that originates from the ASIS and inserts along the anterior medial aspect of the tibia at this region called the pes anserinus muscle group. It's just FYI, you need to know that. But rectus femoris is this muscle here, the most superficial quadriceps muscle. Notice that along the distal third of the distal femur, it becomes a quadriceps tendon, which inserts right at the patella. Vastus lateralis is found laterally. Lateral to that is the iliotibial band, a thick fibrous band of tissue and fascia. Medially, we find the vastus medialis muscle. It's shaped like a teardrop. And then you have your iliopsoas group right over here. Iliacus originates from the iliac crest and inserts on the lesser trochanter of the femur. And psoas major that originates from the spinous processes of the raised from the lumbar vertebrae and inserts down into the lesser trochanter for the action of hip flexion. These muscles we've gone over several times already in the last few presentations. Medial compartment or the inner thigh. Pectineus we just discussed. So all these muscles anchor or originate from the pubic bone, the pubis region. When they contract, they pull on the inner thigh, bringing that leg towards the midline. That is why they're found on the medial compartment Notice that these are listed alphabetically and anatomically. As you can see, adductor brevis, longus, and magnus. We're going to go further down. So pectineus, brevis, longus, and magnus. It's a better diagram. Next few slides with these pictures here. But brevis, longus, magnus, BLM. Posterior externus is this muscle found intra-articularly. This one is primarily located deep within the front. And then the posterior compartment posteriorly consists of these three muscles, otherwise known as the hamstring muscle group. You have the biceps femoris, which is most lateral, semitendinosus, which is in the middle where two immediately found, and then you have your semimembranosus, which is found medially. I would use the atom E and membranosus to signify immediately, and help you locate where the muscle is located. Their main job is to perform knee flexion. Keep going along the anterior compartment of the thigh. The majority of these hip flexors and knee extensors are innervated by the femoral nerve. That's important to know. I'm just primarily concerned with your pectineus muscle being in the medial compartment to perform hip adduction, which is the same as hip joint abduction and thigh abduction are the same thing. Clinically, iliopsoas, as we know, it does hip flexion. Sartorius is one of the longest and most slender muscle in the human body. Primarily, we're concerned that it does assist with knee flexion. That's a primary motion that I'm concerned with. Slender man here, just to help you remember that it is a slender muscle. Quadriceps femoris, these four muscles that we just discussed earlier. The rectus femoris has two functions because of its origination at the iliopsoas. It performs hip flexion or thigh flexion, and also helps to perform knee extension. Vastus lateralis, intermedius, and medialis all perform the same function of knee extension. So all four muscles conduct knee extension. The rectus femoris does a hip flexion in addition to knee extension. So that's a big key difference there. Here's a diagram that shows what we just discussed. We got your iliopsoas muscle group up here, iliopsoas major, originating from the lumbar vertebrae, inserting to the lesser trochanter, as well as your iliacus, originating from the iliac crest or sartorius, your long slender muscle that goes from the ASIS origination to the anterior occipital tibia. Quadriceps femoris muscle group, you got your rectus femoris, vastus lateralis laterally, vastus medialis medially. The vastus intermedius is just inferior to the rectus femoris. The pectineus originates from the pubis and inserts on the femur, causing abduction of the hip joint, the thigh, and you've got your brevis, longus, and magnus and gracilis adductor group to help you with that. Concerned with basically the insertion origin is your final thoracic vertebrae T12 and 1 through L5. It's the origination of this muscle. Inserts in the lesser trochanter of the femur. Basically, it helps to, when it contracts, it anchors in the lower back. It helps to flex your hip. That's mainly the main concern I'm with right now, hip flexion. There's different types of the terminal nerves in the lumbar spine. But primarily L1 through L3 is the spinal nerve root or lumbar plexus there. So here's some more diagrams here located to show you the iliopsoas major and the iliacus found within these two combined make the iliopsoas. Here's some more diagrams for you as well. So iliac crest and part of your sacrum, flexor trochanter help with hip flexion. That's what I'm concerned about. And then femoral nerve is the innervation. Its origin, spinal nerve roots are at the L2 through L4 levels. Okay? So you want kind of get a list of all of these innervation names and write next to them in a column of some sort the spinal nerve origination. Here's some more diagrams showing this. Now, here's some more information here. The sartorius is also known as a Taylor's muscle. As I mentioned in class, when you cross that leg over for the Taylor's, when they'll be sewing something like this. Right here, the sartorius insert gets a little irritated and inflamed, and painful instant palpation there will cause and elicit a reaction from the patient. That's why it's called the Taylor's muscle. It gets irritated most of the time from being in that position for a prolonged period of time. This joint originates from the ASIS and crosses over the knee joint, crosses over the hip joint. That's why it says here it crosses two joints. Primarily, it flexes the knee joint and does most of these other actions as well. Femoral nerve is the innervation emanating from the L2, L3 spinal nerve roots. Here's our diagram showing the sartorius. So the pectineus, if you'd like to help you remember the origin, is the pub. Publix supermarkets, go shopping at its pleasure. Pectineus muscle originates from the pubis, and search right at the femur. Just distal to the lesser trochanter. That's not important, just as long as you say femur, because when this thing contracts, it's going to pull the femur immediately toward the midline, causing hip joint abduction. Understand that it's innervated by the femoral nerve, the portion that originates from L2 through L3. I mentioned in class that the pectineus is the shape of a Publix it's half order. Just help you remember the origin. Here's the pectineus muscle combined with the rest of the anterior thigh muscles. The quadricep muscles, here they are once again. Primarily, I'll just be able to identify these on the structure. Not going to go in depth on the intricacies and then show the origin of the quadricep muscle. They are a very powerful muscle group and they help with knee extension. Femoral nerve L2 through L4 is the entire four muscles, spinal nerve root origination for this muscle. So they all attach to the superior patellar region through the quadriceps tendon. That tendon surpasses the anterior part of the patella, then it is called a different name, the patellar tendon, and then much further down the infrapatellar tendon, which then inserts in the tibial tuberosity. Rectus femoris, that's where it's located anteriorly. Vastus lateralis, vastus intermedius, which has a location just inferior to the rectus femoris. Vastus femoris obliquus, that's another term for it. Looks like the teardrop muscle as we discussed in class. It's located, and here's some more imaging from the anatomical machine. So I'll get to know these structures and where they're located. This is an excellent one here. They pectineus, adductor brevis, adductor longus, magnus, and then gracilis. Notice that they're all originating from the pubis. and attaching to different parts of the femur, causing hip abduction or thigh abduction, bringing it this way towards the midline. For the medial compartment, you only know that the main nerve that's innervating this is the obturator nerve. Just be able to identify these muscles on structure, and that they originate from the pubic region and insert on the different parts of the femur. I'm not going to get too specific on that, but the main function will be to perform hip abduction and deduction. One thing can help you to understand, you can say hip adduction or hip abduction instead of saying add and abduction, because I know it sounds similar, it can get confusing if you don't say them correctly. It's just another pointer for you guys. Most superficial muscle on the medial thigh, yeah, it's nice to know. I'm not going to test you on it, but it's right here. It just, right on the inner thigh, helps to abduct the thigh. Like I mentioned, all these are coming from the obturator nerve. Just know that it's found in that medial compartment and is one of the hip abductors. But I'm not going to delve too much on the gracilis. Really identify what's on there, but not too much. It's going to be asked about that muscle. So you have your adductor pectineus, which we discussed, and that's your public submuscle. If you have not had a public sub, if you're new to Florida, make sure you go get one before tomorrow's final exam. Give you energy to pass the test. And so we got your pubis as the origin, different parts of the femur, these things insert that, just know that, say femur, I'm okay with it, and it's going to cause hip adduction, adduction. You know where these are located, like I said, they're, except for the pectineus, you start with the adductor brevis, longus and magnus, BLM, the peanut butter, like something else. Just know the adductor brevis, longus, magnus, fill in alphabetical order, and the obturator nerve innervates the entire medial compartment. So there you go. If you group all these muscles in saying that you have your pectineus, adductor brevis, adductor longus, adductor magnus, gracilis, those are all part of the medial compartment of your thigh, and their main function or action is to perform hip joint adduction, or thigh abduction, same thing, and they're all innervated by the obturator nerve. Okay, basically that's what the main meat and potato, as they say, of this portion. So yeah, with the magnus, like I said, I'm just concerned with obturator, pubis origin, and that adductus back. All these other minutiae, don't worry, we're not there yet as far as our evaluation skills are concerned. For the portion, it's going to be basic clinical anatomy. Operator externus, I mentioned in class that we probably won't be going too much in depth in these. These are very small muscles within the medial compartment, primarily at the hip joint. They help to perform external rotation of the thigh and help to stabilize the femoral head within the acetabulum. This is part of the joint capsule that we cut into in doing hip surgeries. But I don't know about that one too much. I would know your borders of your femoral triangle. Superiorly, you have the inguinal ligament. Medially, you have the adductor longus, and then the sartorius is the lateral border of the femoral triangle. I would know these. It's basically similar to the inguinal region, where herniation of the intestines can traverse through. This one is inferior to the inguinal ligament for under the GI, and the abdominal anatomy is that the other part is superior part where the spermatic cord is located. This one's inferior to it. The floor of this is basically your pectineus abolocus. But just a little bit of minutia there for you. Your femoral artery, nerve, and vein. This is located within there. This is just FYI. So, just like the spermatic cord had a sheath around everything there that was important, this is a femoral sheath that contains the femoral artery, vein, and lymph nodes. It helps to kind of protect these structures as they pass through this femoral canal. This is what will look like with a femoral hernia, where the intestines will go inferior to the umbilical and then and traverse out through the femoral sheath. When we talk about the vasculature of the lower limb, I'm more concerned with the femoral artery. This is the big blood supply to the lower extremity. Has many branches that branch off of this, but an injury to this high pressure large artery and is not tended to, and a reason by the time leads to imminent doom for the patient. What we're concerned with is the femoral artery, and the medial circumflex femoral artery is the one that supplies blood to the femoral head. In the neck, if there's a femoral neck fracture, that femoral head cannot get blood supplied and will lead to avascular necrosis and bone death. So I would know what blood supply to the femoral head is, which is the medial circumflex femoral artery. Profunda femoris, yeah, nice to know, not going to ask anything like that. So basically, just know medial femoral circumflex arteries plus femoral head. It branches off of this profunda femoris artery, but I'm not going to ask you that. Just know what the blood supply of femoral head is. That's sufficient enough for clinical anatomy and examination skills. Also, if there's arteries, there's going to be veins that help to drain the exhaustion of blood through that. I'm going to ask you that. Know your gluteal muscles. I know we discussed these in block 3. Now I want you to know these red areas you see there, the red font. Anything that's lateral rotation is going to be flexion rotation, medial rotation, internal rotation, and so on and so forth. Know the actions of these muscles from having this slide right here. Now you have deeper muscles that help to conduct external rotation, stabilize the hip joint. Either piriformis, obturator internis, the gemelli brothers or gemelli twins, see very few in class. I'm not going to ask you too much about these as far as anything medial about the piriformis, but the rest of these are just these deep muscles that help to stabilize the joint. Are smaller, they're more significant for surgery versus clinical anatomy right now. Glute medius, to be able to highlight where it is, it's going to tend to breast therapy is maximus and larger muscle, regions from the right crescent part of your sacrum, and then your piriformis muscle. Most of the time that sciatic nerve goes underneath there, and when someone has a wallet on their back pocket and sitting on it, it will create an uneven nature to the pelvic region and create a spastic state for the piriformis muscle, which will then lead to a pain spasm cycle and transient numbness and tingling down the posterior element of the affected lower extremity. Gluteus maximus, as mentioned in class, it originates, main thing I want you to know about this slide is that it is innervated by the intragluteal nerve and the spinal nerve, which are L5 through S2. And it's basically going to be a thigh extensor. Know where it's located in the file this one exam, where it's just arrow pointing to. I need you to understand what's pointing to gluteus maximus. You can see that it is its relation and spatial orientation to the glute medius and the glute minimus, which is deep to it. Here's a diagram, a model showing you some of the hamstrings, your biceps femoris, your IT band, or iliotibial tract. For clinical medicine, we call it iliotibial band. Glute medius, which is adjacent to the gluteus maximus. Here's what it looks like on the analog. Excuse me. So glute medius, primary action is abduction, taking that thigh away from the midline, superior gluteal nerve. So we got superior gluteal nerve for glute medius, inferior gluteal nerve for glute maximus, the spinal nerve root origination, 4-2-S1. And they all insert at the greater trochanter of the femur. That's where it hooks into the cause for abduction, abduction. See what's located on the abdomen. And on the other diagrams as well. Gluteus minimus, superior gluteal nerve as well. L4-2-S1 is the origination of the spinal nerve roots. Primary action I'm concerned with is hip joint abduction as well. You see it's in relation to the deeper part of the gluteal muscles. Let's look at on the diagram as well. Here as well. Tensor fascia lata, know that it originates from the ASIS right here. Inserts directly into the IT band, that thick fibrous band of fascia that can get really tight and painful distally. It's named for its origination in ilium, iliac crest, and it goes down towards the tibia proximal knee joint. That's why it's called the IT band. Also the organ insertion, and this one's superior gluteal nerve as well. So kind of group which one's superior gluteal nerve, inferior gluteal nerve, innervate the muscles and the spinal nerve orientation to better assist in grouping these structures for studying efficiently. Where it's located once again, and its relation to the insertion into the IT band. So just making our diagram. Look how deep the piriformis is to the gluteal muscles, gluteus maximus, piriformis. Your hip external rotators. Don't know too much about those. Know that the piriformis inserts at the greater trochanter and originates from the sacrum. It's all originates from the sacrum, inserts from greater trochanter of the femur. Requires also external rotation of the hip joint, and with basically from the sacral plexus, S1 is 2. Just know that it is an external rotator of the hip, inserts after the greater trochanter and originates from the sacrum. Up greater in terms of one of these deep muscles of the hip joint. Two of that guy, the gemellus twins. Also very deep muscles, more concerned with orthopedic surgery. This one as well. But we're concerned more with the heavy hitters or quadriceps and hamstring muscle groups. Hamstring muscle groups, so semi-tendinosus, obviously by extension. Semi-tendinosus is much more medial. You can see it here. Sorry, semi-tendinosus. Medial, this thin semi-tendinosus also overlies it, but it's intermediate in between the biceps femoris over here, as well as the semi-membranosus medially. Remember MB for medial. Biceps femoris, I just want you to locate, and then it does in flexion. There's long head and short head. But for our intensive purpose for the exam, I don't want you to differentiate between the two at the moment. Semitendinosus, origination is ischial tuberosity. That's the majority of all your hamstring muscle groups, is the origination at the ischial tuberosity. We are actually sitting on our ischial tuberosity right now. Main job is to perform a knee flexion. It can also help with the thigh extension, but the primary big job it does is knee flexion. Tibial division, and that sciatic nerves bifurcates at the top of the tibial fossa into a tibial and peroneal nerve, innervating different structures as well. Here's some more diagrams here, models that we found for you here. Get familiar with these, really feel identify these. As well as some tendinosis. The student is telling me for the IT and tendinosis is intermediate, so intermediate between biceps femoris and the semimembranosus, which is more medial. Semimembranosus, same as the other two guys there, originates at the ischial tuberosity of your pelvic bone. Crosses the knee joint, obviously, and sits at the tibia to perform knee flexion and tibial division, L5, X1, X2. No structures here now. Let's see what it looks like on the anatomy march. So notice we're just basically concerned ourselves with 4 quadricep muscles. The rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius, and then the 3 hamstring muscles, biceps femoris, semitendinosus, and semimembranosus, and then we'll have a little bit of side muscles there, such as the tensor fasciae lata, the glute maximus, medius, and minimus, and piriformis. Focus on these muscles and what I told you previously, and you should be fine for the examination. There's 2 heads to the biceps femoris, like I mentioned. This balance just goes on ischial tuberosity, and this muscle goes knee flexion. I'm not going to make too much minutia between a long head and a short head. I don't have time for that at the moment. This is where it's located. The sciatic nerve. So spinal nerve roots emanate from the L4 intervertebral disc, L5, L4, L5, L5, S1, S1, S2, S2, S3. It's basically a huge wall of nerves fusing into one huge sciatic nerve. That's basically what comes out. You can see it's inferior to the piriformis. So obviously, if you have a wallet here and this muscle is contracting from doing off balance in the chair, is going to cause it to contract, create a pain spasm cycle. You start pressing down on that sciatic nerve, kind of like if someone were to step on your garden hose while you're washing your car. The signal is not going to be transmitted fully. They're going to little bursts, and transient the numbness and tingling will soon follow. But yeah, mostly leg and foot muscles. Understand that at the top of the tibial fossa and close to your knee, it bifurcates into 2 separate nerves, a tibial and peroneal nerve, and those will innervate certain parts of the lower leg as well. Now, common tibial nerve, that's going to be the peroneal nerve, so please alter that. I do apologize. We're still having these anatomist nomenclature in the clinical anatomy course. I mean the tibial nerve, okay? So, the popliteal fossa, I mentioned in class, create a diamond with your hands. You've got your superior parts here, superior medial portion. These are semimembranosus and semitendinosus muscles. Superlaterally is your biceps femoral region. And here is your medial and lateral gastrocnemius heads. Notice the important structures you see here: popliteal artery, vein, and nerve. These are commonly injured with knee dislocations and traumatic, we call them bumper fractures, tibial plateau fractures that are at the level of the bumper of the vehicle. Those get struck, causing tibial plateau fractures, knee dislocations, and the severing of the arteries and veins and nerves in this region, leading to potential limb loss and amputation. Triangular space posterior of the knee, as I just mentioned. You just know that there is a vein, artery, and nerve in it, like we've always done, navel. I'm not going to ask you specifically what's in there, but just know that it's there. Anterior compartment of the leg, this is your muscles that work extrinsically to dorsiflex the foot. Tibialis anterior, the large one anteriorly. If you reach down and dorsiflex your foot, you actually feel it contracting. Extensor torum longus, similar to the extensor torum in your hand that extends the fingers or the digits. This one extends your toes. Extensor hallucis longus for your hallux, your great toe, will help perform an extension of the great toe. And your peroneus tertius, will help with foot eversion and dorsiflexion of the ankle joint. Same thing for foot and ankle movement. So as I mentioned earlier, sciatic nerve at the level of popliteal fossa splits into two different nerves like a cobra's tongue, a common peroneal nerve. For our intensive purposes, that's all I want you to know. It goes into more in depth between a deep peroneal nerve and superficial peroneal nerve. I just want you to it's peroneal nerve at the moment. Just for our intensive purposes, we'll keep it at that. You can see here we have your sciatic nerve. It traverses through the popliteal fossa region. Right here, it bifurcates into your common fibular nerve. And then over here, it turns into your tibial nerve. Now there's a deep peroneal and superficial peroneal nerve. But like I said, I just want you to know that it bifurcates into a peroneal nerve laterally and a tibial nerve medially. And how we know if we're lateral or not, we find the fibula, which is right here, a little white line, little fib. So if you reach down and you have to keep your foot, that's where it inserts along the medial cuneiform, basically first metatarsal. That's the insertion. Basically, the proximal tibia is where it originates from. You actually feel it there. Dorsiflex, and then what's the foot is the action, and just know it's the this thing so I do apologize for that. It's your peroneal nerve, but it's okay. I'm only going to be concerned with what the action is. Major compartment in that foot. So here's some more images here. We got your tibia bone, tibialis anterior muscle. This video on the cleft, right in the crest of that tibia. The sensor is one long is adjacent to it. And this would all its tendons are here extended. Here's some more structures here. Here's the anatomy where it's located. Sensor torum longus. Notice where it's located right there, interlaterally. And all the tendons that help to extend the toes, the lesser toes as we call it. Sensor hallucis longus extends the hallux, or the great toes, as we call it in normal talk. It's basically located here in the middle part of the intercircular fibula, and the fibula. It originates from the fibula and starts along the dorsal aspect of the phalanx of the great hallux there. Peroneus tertius, not too concerned about this one. The other ones are more important. So we got your proteus longus and proteus brevis muscles. As I mentioned in class with the diagram, you're going to see that the proteus brevis inserts at the base of fifth metatarsal and helps to invert that foot. Proteus longus literally goes and traverses and inserts at the first base of the first metacarpal along the plantar of the foot. Now, like I had you guys in class, where we palpate your fibular head. That is where the peroneal nerve is located. Superficial. If you put an ice pack over that area, it will cause numbness to the area and it will lead to limited dorsiflexion. You get kicked in that region or suffer some trauma or the nerve gets damaged, you're going to have difficulty performing dorsiflexion ankle, which is known as drop foot. So we know basically these two muscles are found in the lateral compartment and we do a foot eversion. That's basically what we're concerned with. Proteus longus, so as mentioned, base of the first metatarsal and the cuneiform. Just notice your I apologize. I'd like to change the superficial peroneal nerve and understand it comes from L5. This one has two, but know the insertions differences between the proteus longus and proteus brevis, and that they are foot everters. Basically, what I want you to know for that. Posterior compartment leg consists of your gastrocnemius, soleus, and plantaris musculature. Your gastrocnemius is a fast twitch muscle built for speed and power. Soleus is a slow twitch muscle fiber muscle that is built for endurance training and running. Plantaris just helps to plantar flex the foot. It's a very thin muscle, as you can see here. Most of it is tendon. We use this tendon for grafts as well in surgery. Soleus is a more robust muscle filled with mostly slow twitch fibers. Here, gastrocnemius is dissected here. This is your Achilles tendon or tendon of gastrocnemius in the anatomy's language. It's called your calcaneal tendon as well. But for instance, we call it the Achilles tendon, and when you search retrocalcaneal along the calcaneus region. This is your superficial group. Your popliteus muscle helps to flex your knee. This is where it's located. Courses from the lateral femoral condyle towards the posterior tibial region. Flexor longus helps flex the great toe. Longus helps to flex the lesser toes. Tibialis posterior, basically intimate to the posterior part of the tibia, and helps to perform plantar flexion. So notice that the gastrocnemius muscle does cross the knee joint as it originates from the lateral femoral condyle, medial femoral condyle up here, and inserts into the retrocalcaneal region through the Achilles tendon. It helps to plantar flex, and tibial nerve is the innervation, and the spinal nerve origination is also in this too. Some diagrams here showing the muscles where they're located. So proteus brevis and the longus, pretty much here to the longus overlap each other, like this. That's where they're located in the lateral compartment. Posterior and lateral. And here's your gastrocnemius. So, like mentioned, here's your medial hypergastra in yellow. Soleus is basically a much deeper muscle. It is an endurance muscle. That's what's called a workhorse. It does not cross the knee joint, so it originates from the fibular head and medial border of the tibia. So remember, gastrocnemius originates from the medial femoral condyle, lateral femoral condyle. Soleus does not cross the knee joint. If you guys have done seated calf raises in the gym, you're primarily focusing on strengthening your soleus because your knee is bent and it's not crossing the knee joint. Now, when you're standing tall and doing toe raises, this is coming off the ground, you're focusing more so on the gastrocnemius because the knee joint is straight and crosses the knee joint. So it originates from the head of the fibula, medial border of the tibia. So you just say head, fibula, head, and tibia. Okay, we've got medial tibia. And inserts into the Achilles tendon. In terms of calcaneus bias, the Achilles tendon helps the plantar flex in the tibial nerve, S1, S2, and RU innervation. And it's nerve roots. Here's some other structures for you to know. And I'm not just well showing the soleus in relation to the gastroc. The plantaris muscle is pretty much it's one of your weaker plantar flexors. Like I said, we use this tendon grafts. I didn't mention anything else about that. So tibialis posterior is very intimate to the posterior tibial region, and basically helps the plantar flex the foot. It has multiple insertion sites. I'm not going to have you know that, but just know that region's from the posterior tibia, and that's one of the deeper muscles in your posterior compartment. Popliteus, lateral femoral condyle is the origination, as you can see here, and it starts on the posterior tibia. Okay, this one has an inflection. It's innervated by the tibial nerve, L4, L5, S1, it's a spinal nerve root, so it originates from flexor iliacus longus, or FHL. We call it the push-off muscle. Basically, the foot pushing off like the arm yourself forward, like the toe-off phasing gait. Notice the insertion here, distal flange of the big toe. It helps to flex the liquid toe. That's where I want to shoot in. So the action is great toe flexion. P joint, MTP joint, anything of that nature. And it's originated by the tibial nerve, originating from S2, S3 spinal nerve. So, also the flexor to return along the same thing, does the opposite, extensor return. Does flexion. Here's your plantar fascia. It's just a thick band of connective tissue to help maintain the posture of the arch of the foot and be prone to injury. The arch of the foot, it's clinical. We don't need to worry about the intrinsic foot muscles. The foot muscles here. So if I were to ask you where the dorsalis pedis is located, like if I'm lost and I'm asking for directions, where's the nearest town? Somewhere I'll go. OSI sensor this tendon, or we also call it EHL tendon. And just be able to identify where it's located here, okay? We all know our subtalar joint, which is the talar-calcaneal joint, which is right here. Here's your talus, and your calcaneus, and creates this joint called the talar-calcaneal joint or subtalar joint. The transverse tarsal joint basically is just going to divide the hind foot from the midfoot to the forefoot. So between the hind foot and the midfoot, you have a transverse tarsal joint, which is basically we call calcaneal cuboid and talar joints, talus, navicular, calcaneal cuboid joint, transverse tarsal joints. And you know that you can see all of the subtalar joints. So inversion of the ankle, because the subtalar joint, as you all learned from PE class, and this is primarily responsible for this are tibialis anterior and posterior. Ankle everters are Bonazones and brevis. It's time for